Hello and welcome to this GovConnect event sponsored by Chiron. Over the next hour, you're going to hear from a couple of experts in the national level and one of our clinical leads about artificial intelligence and breast screening and the potential it may have. You'll be hearing from colleagues within NHS England and Accelerated Access Collaborative from HSX and our clinical lead at Leeds Teaching Hospital. I'll also be following up with a bit of overview about what we're doing within Chiron as part of the AI Award. During the session itself, you'll have the ability to submit questions, so please do log your questions as we go along. We've put in time deliberately to do a Q&A session at the end, so we'd love to hear from you and have a chance to discuss what you've raised within there. But without further ado, I'm going to go around and get the panel to introduce themselves and say a bit more about who they are and where they're from, and then we will go into the presentations. So Dan, over to you.
Thanks, Simon, and good morning, everyone. I'm Dan Bamford. I'm one of the deputy directors in the Accelerated Access Collaborative, which is a group that brings together the NHS industry, medical research charities, and patient representative organisations to support innovation in the NHS. And my role within the AAC is to look after the Artificial Intelligence in Health and Social Care Award. So it'll be great to talk about that later.
Fabulous. Thank you, Dan. Ellie?
Yep, so I'm Ellie Harwich, Head of Collaborations at the NHS AI Lab, and I have the pleasure of being Dan's colleague. So as Head of Collaborations at the NHS AI Lab, I basically focus on making sure that the different delivery programs that I will talk about in my presentation later achieve their stakeholder strategic engagement goals, as well as understanding how to communicate about the outputs that they produce. So I guess I also see my role internally and within HSX as trying to break down some of the organizational silos that we have and make sure that we all work together in order to make sure that there is safe and ethical deployment of AI in healthcare.
Hi there, I'm Dr. Nisha Sharma. I'm a consultant breast radiologist and director of the breast screening programme for Leeds and Wakefield, and I'm delighted to be here. I'm going to talk about the impact the pandemic has had and is continuing to have on breast imaging services, particularly breast screening. Thank you.
Simon, you're on mute.
Sorry, hello everyone. I'm Simon Harris, and I'm the Senior Project Manager at Chiron, and I'm overseeing the delivery of the award, the AI Award, from a Chiron technology point of view. So I'll be talking a bit about that towards the end of the session. Okay, Dan, I'll hand over to you now to go through your presentation, and then we'll go from there.
Brilliant. Thanks, Simon. As mentioned, I run the AI in Health and Social Care Award, which is a large grant pot that's administered by the Accelerated Access Collaborative. We run this programme in collaboration with our partners at NHSX, and Ellie will talk about the kind of wide range of work that the AI Lab within NHSX do. And we also run the programme in collaboration with our partners at NIHR, who have a world-leading expertise around kind of running grant processes and helping support some of the most innovative companies the UK has in this field. Thank you very much. Whoever changed the slides. So first up, I think it's worth reflecting on the scale of our ambition and scale of the perceived opportunity. So we really believe that artificial intelligence has a huge role to play in shaping the delivery of healthcare services in the short term, medium term, and long term. So we really think there's going to be a fundamental revolution here. And we had kind of earlier this month, the chief exec of Google talking about how he sees AI as potentially more transformative than the internet, more transformative than electricity, and more transformative than fire. So kind of they're very bold ambitions in the sector more broadly, and we certainly share the spirit of that in terms of how we can apply AI to health services. And what we're already seeing in the NHS is the early application of AI technologies across a number of sort of core kind of themes. And we've laid out here some of the areas where we see sort of machine learning techniques making a big contribution. And through the award, we're already funding technologies across each of these four categories. So we have solutions that use natural languaging processing techniques to help kind of harness insights from unstructured data. And we've got tools that help support referrals and help support coding in that space. There's a really exciting category of technologies looking at how do we sort of obtain insights from our imaging modalities and our reporting. And there's a lot of funded technologies through the award in that space. There are also technologies that can classify or prognosticate and give a view about the potential for certain data indicating the presence of disease or other risk metrics. And then lastly, we also see big potential for AI tools to help support the planning of services through improved forecasting of demand and capacity. And we support tools that help support the planning of theatre time, the planning of outpatient booking slots as examples of what we see in that space. We could move on, please. So the award itself is a £140 million grant pot that we're spending over 4 rounds, and we essentially conceive of the grants as supporting technologies across 4 phases. So in phase 1, we have our earliest stage technologies, or our least mature technologies. These are really at the sort of early prototyping, feasibility type testing phase. And we have given kind of small grants to technologies in these phases. We then move up to kind of phase 2, where there are algorithms and solutions ready to be tested robustly in a lab-based environment to check for their accuracy, efficacy, and suitability for deployment. And again, we make sort of relatively modest in terms of the AI award grants here, but they can be material and up to 1.5 million. We then move into the real world testing phases in rounds 3 and 4, where as you move through rounds 3 and 4, you essentially run real world testing of the technologies at greater and greater scale. And when you get into phase 4, we look at making grants of up to 7 million typically. So in that real world evidence phase, there's some really bold ambition about testing these technologies robustly and at scale. The purpose of all of this being to effectively pull technologies through the 4 phases and get them to what we describe as phase 5, which is post-award supporting these technologies to get commissioned and embedded in the NHS at scale off the back of very comprehensive evidence that meets the required standards set out by partners like NICE and Public Health England. If we can move on to the next slide, please. Thank you very much. So in terms of our award process, we've completed 2 of the 4 rounds we plan to run. And across those 2 rounds have committed about £90 million of our total £140 million pot. And we're currently sort of in the early stages of round 3, which I will dutifully plug later on in this presentation. This map sort of describes where our late stage technologies are currently working in the NHS in England, but also in Scotland and Wales. And this gives a sense of, again, the scale of what we're trying to do and how we're trying to think about testing and deploying these technologies across the whole of England and the United Kingdom, and making sure that patients everywhere, clinicians everywhere benefit from these technologies, and that they don't stay within the confines of traditional academic powerhouses or sites that would traditionally be seen as digitally more mature. So where are we now? We are in the really exciting phase of having opened our 3rd funding round, which closes on the 7th of September. And then subsequent to that, there's our internal process of shortlisting and ultimate decision making, which will mean we announce our 3rd cadre of winners in early February next year. So certainly if there's anyone in the room who's thinking about should they or should they not put in an application, now is a great time to be engaging with my team, and there's lots of guidance out there, but we're really happy to talk to any would-be applicants. Move on. So that's the kind of core of what I'd like to talk about today. There is a lot of guidance available on what we're doing through the award and what our ambitions are from a kind of broader perspective. The message I like to sort of leave the audience with is, and I'm sure Ellie will sort of echo this as she talks about our engagement more broadly, is that to do this effectively and to make sure we're supporting the best technologies and then working with them in the optimal way to ultimately kind of pull them through into the NHS sustainably and ensure they're deployed in a safe and ethical way, we really need the support of everyone on this call, be you a clinician or be you in an operational role supporting these technologies. If you're in the evaluation community, if you're a developer, we really need to understand from you about how we can deploy these solutions more optimally. And of course, I just want to finish in saying that the key to doing this correctly will be ensuring that the patient voice is heard through all of this. So I'm not sure if we've got patient representatives on this call, but again, really keen to hear from you about how we do this. And there's some really exciting work that I might be able to trail later on around what we're doing on patient and public involvement and engagement. So thank you, Simon.
Thanks very much, Dan. That's a really helpful context and overview in terms of the AI award and where it's going and the rounds for applications. I can see we've had a comment come in around stage 2 will be Feb 2022. Is that correct?
So we are not running phase 2 for the next round. But we currently have it open for round 3. So people applying in round 3, which is currently open, could certainly apply if they're in phase 2.
Great. Thanks for the clarification, Dan. Okay, handing over to Ellie now, Head of Collaborations at NHS AI Lab. Ellie, over to you.
Yep, great. Fantastic. So I thought that with this presentation, I would give you a kind of whistle-stop tour of all of the work programs and activities that we run within the lab, and also focus towards the end of my presentation on the national strategy for AI in health and social care that we're currently working on. So is that? I'm not seeing the slide change. Is that changing the slide?
Yep, we can see that change on ours.
Oh, okay, great, sorry. Okay, fantastic. So just as a bit of context as to where the NHS AI Lab sits, it obviously sits within the broader NHSX family of different teams working on different aspects of the deployment of technology within health and care. So the AI Lab was established in 2019 to explore the potential of AI to improve health and adult social care services and to improve, obviously, the public's general health and well-being. So as I mentioned earlier, the AI Lab is set up around a suite of programs in partnership with other health and regulatory bodies in the UK, and really here the idea is to be able to accelerate the safe rollout of ethical and effective AI. So as you can see, obviously, it's very important for the AI Lab to work in collaboration with other teams, such as, for example, the data policy team, because obviously, you know, without data, there is no AI, but also looking at partnerships potentially with the Center for Improving Data Collaboration, which is looking at how to improve value sharing agreements between the private sector and the public sector when there is a data partnership. And so basically kind of working in collaboration with the rest of the NHSX teams ensures really the kind of success of the AI Lab programs. So in terms of our key mission, the AI Lab has a clear mission, which is to enable the development and safe adoption of ethical and effective AI in the UK. And to be able to do so, obviously, this translates into 3 main goals that we have. So one is to demonstrate the potential of AI-driven technologies for health and care and build an understanding among the public and healthcare professionals about the potential of this technology. And I think this is really important and actually speaks to most of the work that is done within the AI Awards program, is really being able to demonstrate how these technologies function within a real world environment, and ultimately demonstrating how they can change the way that we deliver care, how they can improve people's health outcomes, and how they can also ultimately alleviate the burden of some of the work that healthcare professionals face. Hopefully, through doing that, it encourages the reaching our second goal, which is around building trust and confidence in these technologies. So both amongst the public and healthcare professionals in the use of AI, because obviously by demonstrating its potential and that it genuinely delivers change, we hopefully will build the trust and confidence of healthcare professionals. However, we obviously know that none of this can be done without reaching our third goal, which is to advance robust regulations. So obviously, the AI Lab is very much focused on ensuring that health AI is safe and effective, but also that those opportunities are equally distributed across the market. So hopefully in my next slide, you will see the structure of the lab. So hopefully this is not too overwhelming in terms of the amount of information. I won't be focusing too much on the AI in Health and Care Award, as we've just heard about this from Dan. But as you can see, we have 4 other delivery programs. So one is looking at AI imaging. And so the AI imaging program is a really interesting program supporting the development of imaging technology. And it kind of started off, I guess, as one of those COVID silver linings, so to speak, where a national COVID chest imaging database was created in order to be able to improve the understanding of the virus and support the development of AI-driven technologies around COVID-19. And really the kind of point of the national imaging, COVID chest imaging database was to be able to look at how to go about validating these algorithms. So actually quite a lot of work within our imaging program relates to some of the work that we do within regulation and the broader agenda that we have around the safety, evaluation, and effectiveness of AI. We also have another program which directly supports the delivery of technologies within health and care. So this is generally looking at supporting these technologies for health and care organizations and arm's length bodies within the healthcare space. So this is our skunkworks program, and the idea here is to support health and care organizations with some, I guess, general data issues that they face, where AI might be applied to solve these problems. So, for example, the skunkworks team established a really interesting partnership with NHS Resolutions to try and understand which factors were most predictive of trusts potentially eventually receiving claims. And so obviously the interesting thing about that project is once you start understanding which factors are predictive of potentially receiving these claims, you understand, well, actually, firstly, which data sets are necessary in order to be able to actually accurately predict these claims. And then you start being able to identify where you might be able to intervene earlier in order to avoid these claims happening in the first place. And the AI skunkworks basically kind of helps these organizations to achieve a proof of concept around this and really demonstrate what's the most appropriate AI model to be able to use to solve these problems. It has done many other projects in partnership with other organizations, and I'm very happy to touch on these during the Q&A. And then we have the 2 subsequent programs around the kind of, I guess, the safe and ethical deployment of AI technologies in the health and care system, which is a whole program of work that we have around regulation and another one looking at ethics. So the program of work that we have around regulation really focuses on trying to optimize the regulatory pathway so that we really try and minimize points of friction that might add to the timeline that private sector companies face when actually going through the regulatory process. So here, really, the project is started off by identifying some of the pressure points within that regulatory pipeline and is seeking to address these. And in addition to that, we are funding through this regulation piece of work that we have the creation of a multi-agency advice service for regulation. So this will hopefully help innovators interact with the regulatory system just through a single front door. So this multi-agency advice service will be hosted within NICE and hopefully provide a kind of singular front door to for innovators to interact with the complex regulatory landscape within health and care. There are also a whole host of other projects within the regulation portfolio that are really interesting, looking at how, for example, synthetic data might be able to be used for validating algorithms and the potential that might have in terms of the kind of processes around the validation of algorithms. But obviously, regulation doesn't protect from potentially doing some ethical faux pas in the area of healthcare, because obviously ethics is a much broader field than regulation. And so we have decided within the AI Lab to tackle those kind of thorny ethical issues really head on. And so we are supporting a variety of research projects for now, and then hopefully translating into policy frameworks. So one is trying to understand how we might go about doing algorithmic impact assessments. So this would really enable AI developers to try and think about some of the potential negative externalities that might come about from the implementation of their technology within the health and care field, and understand how they might go about mitigating against those risks. Also, I'm sure most of you will have heard of the potential effects that AI might have in terms of entrenching healthcare inequalities. And so we have funded a whole host of research projects actually looking at the reverse of how AI could potentially be used as a force for good or as an equalizing force to try and mitigate against the impact of healthcare inequalities. And obviously, as you can see also, there are 3 supportive teams around strategy and policy, collaboration and engagement that I am part of, and a program management office. And I thought that I would share some insights around the national strategy for health and adult social care. So this is something that is currently being drafted right now. And so I just thought that I would share some of the broad ambitions that we have with this piece of work, which is being led by my colleagues within the strategy and policy team, and obviously in close collaboration with the collaborations and engagement team, because there is a huge piece around collaboration and engagement in the drafting of this strategy. So broadly speaking, in terms of the ambition that we have, and this is really trying to forward think a bit, if we imagine a future where AI is safe and AI is deployed in an ethical and effective way, we kind of imagined different potential areas or ambitions that we would like to achieve. So one is obviously that people would be able to monitor their conditions at home, and that the results would directly kind of be sent to their GP, and that you would have the GPs assisted in the diagnostic phase of interpreting the results with AI tools. Similarly, clinicians in a NHS trust setting would use AI-assisted diagnostic tools to identify diseases within patients. Also looking at the potential of AI to be used by public health officials to be able to identify patterns across local areas and potentially being able to alert populations around public health emergencies. Then looking also at how AI could potentially be used within AI-driven management systems, or the ambition is that ultimately that is how you would go about managing hospitals. And then finally as well, a kind of AI-driven management system that would give real-time information around waiting times and kind of triage patients based on capacity. So obviously, these are very ambitious goals and goals that we are working on for the national strategy. Currently, the strategy has been kind of focused on 3 types of research phases. So we've carried out the secondary research phase. We have done a whole primary research phase as well, with including a survey around the public, quite a lot of workshops, and have interviewed over 100 stakeholders for this. And all of this will feed in, obviously, to the work of the strategy. And then finally, we have also looked at speculative design. So this is quite an interesting methodology that emerges really from the field of design to try and imagine ultimately what different worlds might look like, more or less futuristic and more or less positive, and understand ultimately what elements of these potential future worlds we might be able to take out in order to frame that kind of future thinking within the strategy. So it's currently being drafted and should be released in the autumn. So please do look out for it. A lot of the engagement activities will be continued after the publication of the first draft. So if you do want to engage with us, please do reach out. And my final slide is now about the engagement. So we have a lot of the engagement and collaboration activities that we do through the lab function through our community of practice and interest, which is known as the NHS Virtual Hub, which is held on the Futures platform. So you just join. There are a lot of discussion forums. You can interact with a lot of the delivery programs that have their own pages and discussion forums on it. You can obviously find out more about our work through the NHS AI Lab website, and obviously follow more information through all of our social media channels, LinkedIn and Twitter included. Thank you very much.
Fantastic. Thank you very much, Ellie. We're keen to, that was really helpful, by the way, thank you. We're keen to make sure that as an audience, you also have a chance to participate in some of our polls. So we've prepared a couple of questions which we will put on now. So Rob, if you can publish the first poll, this is really around perceptions about when we will see routine use of AI in healthcare settings. So just a bit of a temperature check from those that are on the call to see what you think. We can see those coming in. I'll let those run for a few seconds whilst I get ready to hand on to Nisha. So shortly you'll be hearing from Dr. Nisha Sharma, a consultant breast radiologist and director of breast screening at Leeds Teaching Hospital. Nisha will be giving an overview of the situation, as she said, what happens in breast screening now and the challenges as a result of COVID. I can see the polls coming in now. I will give it 10 more seconds and I'll end it and we'll talk through the results. So if you're still to vote, please do. And then we'll end the poll and publish the results. Okay, so the question asked was, we will see routine use of AI in healthcare settings within 12 months. That had 0%. So nobody thinks it'll be in routine use within the next 12 months. That's interesting. Within 1 to 3 years, 30% of respondents felt we would have it in routine use within 1 to 3 years. 43% of respondents felt it would be in place within the next 3 to 5 years. And 26% of respondents felt it would be 5 years plus. So interesting to get a sense from what the audience think of how long that will take to get into place. Thank you very much for that. We've got another poll later on, which we will we'll be launching then. But I shall now hand over to Nisha.
Thank you, Simon. So I don't have any slides for this presentation. I'm just going to talk to you about the impact that the pandemic has had and is continuing to have, I think, on breast services. And in particular, I'm going to focus on breast screening. Now, you'll be aware that when we had the first pandemic, the breast screening programme nationally shut down, and that was for 3 months. And then services, once we realised that we were recovering from the pandemic and we were allowed to open up, services started opening up in July, August time. So some services closed down for 4 months, some for 3 months, some for a bit longer. Now, when we had to reopen our services, the challenge that we had was that we had to maintain safety. We had to ensure that the public, when they were attending for the breast screening, felt safe. We had to make sure that the staff felt safe. And so we had to use personal protective equipment. And that meant we had to change our screening appointments from 6 minutes to 10 minutes. Now, initially, we went to 15 minutes because obviously there was quite a level of anxiety in terms of cleaning down the machines, changing your PPE. So we'd gone from having 100% capacity to going down to 40% capacity when we first started screening. And now we sit at 60% capacity because we've managed to reduce the appointment time to 10 minutes in most centres. And the problem that the services had were not only did we have, when we stopped screening for 3 months, so women who were invited but didn't attend for their screening mammogram, we had to manage them. But we also had women that we didn't invite altogether, who we now needed to invite and get them to attend for breast screening. So you can already see the pressure the system is under, because there was no way that we could do catch up with the increased appointment times. And also public perception, the public were scared. They had the message, stay at home, don't go into hospital unless you have to, protect the NHS. So again, the reticence to come and attend for their screening appointments, it was really difficult to change that culture. And eventually we started making inroads and women started attending for their appointments. But we also then had to change the way we were managing the appointment system. So before the National Breast Screening Programme, we would send out timed appointments. So a woman would receive an appointment saying she had her breast screening examination on Tuesday, 9 AM. And what they would do is they would maybe phone to change the appointment, or they may not attend. Now we're doing open invites. So open invites is where we write to the lady saying that she's due a screening appointment and they now need to contact the breast screening service to make that appointment. So one of our biggest challenges, and which is being looked at, is the infrastructure, the IT system within the breast screening system. It was established in 1988, so it's outdated, and we know that it needs to be modernised. So women weren't able to go online and book their appointments. They had to physically contact the unit or email the unit, and the unit then had to contact the lady to make the appointments. Now, this will have an impact on uptake, and that is being currently investigated and evaluated to see what that true impact will be. But what this means is that when we do run screening clinics, we have very few DNAs because these women have been proactive in booking their appointment and they do tend to turn up. So we've had to change our way of doing things to accommodate the pandemic. So we've moved from timed appointments to open appointments, and we've had to increase our appointment times. Now, this has also had an impact on the staff because during the pandemic, when we stopped screening, many of the radiographers were redeployed to work in A&E, to work in the wards, to do chest x-rays. So they had to learn a new skill set or update their skill sets. And then they came back into screening to then go back to doing mammography, having had a gap of 3 months where they weren't performing mammography. So again, it was a learning curve for them, learning a new skill and then coming back to adopt the skill that they were trained to do. So this has been a really, really difficult time, I think, for the breast screening programme. And this has been compounded also by the symptomatic service, because the referrals in the symptomatic service have increased, and they've increased at a national level. And as a result, there's competing demands because the radiologists and radiographers, well, the radiologists work both in screening and symptomatic. So are you robbing Peter to pay Paul? Which is more important? And then the radiographers as well are having to work in the symptomatic service, are under pressure because, again, our environment isn't a spacious environment. And so we're not able to maintain the 2 metre social distancing. We have to wear PPE all the time. We're a busy environment. And I think what people forget about the symptomatic breast service, it's a bit like being in A&E. It's constant, it's busy, and it's dynamic. You're not sitting at a workstation just reporting scans. We're dealing with patients, we're dealing with queries, we're doing multimodality, we're looking at ultrasound, mammograms, tomosynthesis. So we are extremely busy. And throughout the pandemic, we have continued to deliver a symptomatic service. And we were able to manage that because women chose not to attend unless they were extremely concerned. So naturally, the referral rates went down during the pandemic. And as a result, the symptomatic services were coping. Now that we're out of the lockdown, so to speak, after phase 1, the referrals have increased. And even though we've been in phase 2 and we're in phase 3 of the pandemic, the referrals have just increased. And now the one-stop services are struggling to cope. We're not achieving the 2-week target of 14 days. The referrals that are coming through aren't translating in increased cancer diagnoses. So we've got a lot of the worried well that are coming through. So there's a huge pressure on the system at the moment. And I think we do have to recognise and appreciate the stresses the staff have been under in terms of mental health and well-being as well, because their main focus has been service delivery for the patients. So coming on to that, the next issue that faces breast screening is a workforce crisis. We know that 26% of our radiologists are going to retire by 2025, and there's not enough trainees coming through radiology to replace those consultant posts. So we are already going to have a shortfall in delivering the current demand. And also this is mirrored within the radiographic community in terms of mammographers. It's very difficult to recruit and train mammographers. Now, breast has been fantastic because we've done a lot of skill mix. So we've trained assistants to be able to do mammograms. And we're trying to diversify our workforce so that we can still continue to deliver a high quality standard of care. But it's challenging. And this is where I feel that artificial intelligence is going to have to play an important role, not only now, but in the future. What we need to do is create efficiencies within our working practices. And I tend to look at artificial intelligence in sort of two broad categories, low risk and high risk. So when I talk about low risk, I think if you're looking at administrative processes, I tend to classify them as being low risk because what you're doing is you're trying to take away human tasks and automate them. These processes, most of them are automated anyway, but they're performed by human beings. And if we can automate those processes, we can make things a lot easier and minimize human errors. We also, as we've alluded to in the previous presentations, we can use artificial intelligence to help predict and plan. So you can do round length planning, you can book appointments, do intelligent booking of appointments. You know if women are going to be likely to DNA, do you book more into that session so that the session will be more complete? So there are intelligent ways of using artificial intelligence, which I think we can deploy sooner. So interesting looking at the poll, I think you can deploy that within a year. But what it needs is it needs clinical community engaging with these companies and with NHSX and NHSD to make this happen. Because we're working on the shop floor, we know what we need, and we need to be able to make that happen quicker rather than later because of the stresses that our workforce is currently undergoing. The next aspect is the diagnostic setting in screening, and this is where I had the privilege of working with Chiron and doing the retrospective study as the chief investigator. And we looked at just over 275,000 mammograms and looked at the role of MIA in replacing the second human reader. And we showed with our retrospective study that we could reduce the amount of film reads that require 2 human readers. Now that in itself is a very important finding because that creates system efficiency within your workforce. Your workforce is dwindling. because we've got people retiring, we don't have enough people coming in to replace those posts. So how are we going to maintain quality and deliver high standard of care? We need to start looking at innovation. We need to start thinking differently, and we need to be able to adopt at pace, but provided we have the evidence to show that this is safe. So, and more work is being done in this area to look at how we can take this forward. And that's fantastic that with the NHS AI Award funding, that we will be able to do that. But if we can create system efficiencies where we're not constantly reliant on human radiologists, radiographers to do particular tasks that can be automated, we can then utilise the humans to do the tasks that can't be automated by AI. And that is taking of the mammograms, that is doing clinical assessment of patients, performing biopsies. So there's a lot more that we can actually be doing, but despite the workforce shortage, we can create still a successful programme. So I think we've got exciting times ahead of us, but we need to embrace AI, we need to work with AI, and we need to dictate what we need for our services. If we don't engage in the process, we will end up using tools that don't work for us, and we will be to blame for that because we haven't engaged the process. So I do think that this is an exciting time, but I do think transformation needs to happen at pace, and we can't really wait for more than 5 years for these changes to be adopted because we're currently in crisis now. Thank you, Simon.
Thank you very much, Nisha. Really helpful to get the clinical context and hearing about the operational pressures that you're facing there. Thank you very much. Okay, so to finalise the presentation section of it, I'm going to give an overview now of what Chiron are doing in the AI Award. So you've heard the national context. You've heard what's needed at clinical level. I'm going to give it an overview as to where we're going. So within the AI Award itself, it's probably worth giving a bit of background as to who we are. Some of you will have heard of us, others of you won't. So I'm working on the basis that you haven't heard from us. So we are a small, medium UK AI startup founded in 2016. We just hit our 5-year milestone a couple of weeks ago, which is a big thing for a small tech startup in this environment. Our focus is predominantly on breast screening at this stage. So, we recognized very early on that in terms of acceptability, in terms of how AI might be perceived, the notion of saying this is going to completely replace a human as a black box and there's going to be no interaction was never going to work. So actually, it makes far more sense in a workflow perspective to say, well, how can AI augment a workflow? How can it support humans as part of their workflow? We're very much focused on clinical rigor and robust evidence generation. That is the only thing that's going to fundamentally persuade clinicians that this is safe and the right thing to do in line with what Nisha had said earlier. So all the work we're doing is around that clinical rigor and robust evidence generation. And picking up on the point that Dan said earlier, we're very much driven by our patient and public involvement. And that photograph of the lady in the corner there is Mary Beth Chalk, who herself is a breast cancer survivor and is one of our patient advisors. So she sits on our boards. She helps drive our communications and engagement and really sort of acts as our North Star and keeps us real in terms of what we're doing. This is not about technology deployment. This is about the ability to impact those women who are accessing breast screening services and living our vision, really. So giving any woman anywhere a better fighting chance against breast cancer. So those are the key things about what we're doing and where we are. In terms of a bit of background, so MIA stands for Mammography Intelligent Assessment, and I just thought it might be helpful to put this slide up here to show the difference in the workflow. So as things stand at the moment, the current breast screening pathway is at the top. We have 2 human readers. They look at those mammograms and they either agree or disagree on the outcome. If they agree, it goes through to a recall suggestion or a no recall suggestion, depending on that finding. So if they see something and they want to bring that woman back sooner for assessment, they will select recall. And if they think actually no, routine recall, we'll see her again in 3 years' time as part of routine screening, they'll select no recall. But there are times where you have a disagreement of opinions. So that would go to the arbitrating reader, the one shown in pink there. And effectively, that arbitrating reader might be an individual consultant, it might be a multidisciplinary team or a consensus panel, depending on how the breast screening unit is set up. And they will review those 2 opinions and make an opinion whether to bring the woman back sooner or leave her as routine screening. But in the context of what Nisha said, we are having real issues with the workforce. So the bottom workflow is simply where we think Mia would fit in there. And what we're doing is generating the evidence to prove that. So still having human reader 1, but having Mia as the second reader. And again, going through the agree or disagree opinion, and then either a recall or no recall, depending on the outcome of that one. If there is a difference of opinion between the human reader and Mia, it would go to arbitration. But what you've effectively done in the vast majority of the cases is saying, actually, we've got to that stage with one human plus the AI supporting them. The ultimate decision still resides with humans. It's not the Mia tool that will actually make the final decision. It will make a recall suggestion or a no recall suggestion. It's binary in that sense. So it's probably worth putting a bit of context about how we've got to where we are now. And Nisha touched upon this, but I think this infographic is quite helpful in terms of some of the work we've done to date. So we've recently finished our trial 2, and that was done on unprecedented scale and rigor. So we looked at over 250,000 cases at 7 sites. So that's over between Hungary and the UK itself, because we obviously need to look at the data for UK women. It involved over 180,000 women, and we had a couple of key endpoints. So looking at the sensitivity and specificity, looking at recall rates, looking at the cancer detection rates, and in terms of the interval cancer rate as well. So there's some key things that we had to look at, and all of this is only good if it's generalizable. So it's no good if this works just for one type of machine or one type of vendor or a certain type of woman. If this doesn't work for all women, regardless of demographics, and it doesn't work across multiple vendors, then this isn't going to work. And then we end up inherently putting bias into the AI, which is not what we want to do. So the idea around generalizability and looking at the stratifications is shown in that final infographic on the right. So looking at how that works and how that then may input. In terms of some of the high-level findings of the results then, this is just a slide just to give an overview so you can see where we've come from. So it was the largest AI trial to date, and it was a novel AI radiologist workflow. So in terms of our standalone results, that first blue box, we found categorically that Mia found more cancers than a historical single reader. We know that's not the workflow in the UK, but actually it was good to know that that could then prove and that could then be scalable. In terms of double reading results, so up to 45% of automation of the entire reading workload. So effectively, a human plus AI worked in that configuration 45% of the time without needing to go to that arbitration step because there wasn't a discordance of opinion. The AI as the independent reader was non-inferior in all the metrics. So it was performing as good as a human, and actually it was superior in most metrics. So again, we've got some confidence there that the tool can perform better than we would expect as a minimum. In terms of comparing to national benchmarks, for the majority of the target metrics, the superiority test was met. And compared to traits of diseases detected, the spectrum of cancers detected by AI or the radiologist was nearly identical to the human double reader performance. We don't want to make this process worse by introducing the AI. At the very least, we want to make it as good with fewer humans in the process. But actually, if we can make it the same or better, then we're onto the right route. So the reason why we're here today is we were one of the successful recipients of the first wave of AI in Health and Care Awards, and we have entered into a 3-year program really to try and achieve the following below. So first and foremost, evidence generation to inform national policy. So breast screening, like all other screening programs, is heavily regulated and nationally scrutinized, and AI will only be accepted as a technology if the national bodies themselves accept AI as a valid tool and a safe way of using it. So the work we do in this award is around generating that evidence to inform those opinions to then have that safe adoption. It's going to be independently evaluated. So it's all well and good us as Chiron saying this tool is great, it works, but actually the independent evaluation and that scrutiny saying, yes, these results do stand up, they do stack up is absolutely crucial. I've touched upon it before, but clinical confidence is the thing that will drive this. So is this a tool that's going to be trusted by radiologists and readers? Are they comfortable with what this is doing and what it's not doing? And I talk about genuine patient and public engagement support. So already a huge amount of work done in engaging with women, finding out their opinions about what AI means to them. One of the things we heard very early on was a lady saying to us, well, actually, this is all well and good, but am I still going to see a human receptionist when I go into a breast screening clinic? Am I still going to be seen by a female mammographer? Or is all this going to change? Am I now going to have to go and speak to someone at a terminal or a computer? The bit that is the process of having a mammogram, I want that human contact. And it's about reassuring that none of that changes. This is all around the background reading of the mammogram once it's been acquired. I talked about generalizability, and that's absolutely crucial, and we need to prove that it works for any woman, anywhere, across any modality. And we're looking at doing 3 specific types of studies in the award. So a retrospective study to help further calibrate the MIA tool itself, so improving the performance by enhancing the data it sees. An arbitration reader study, so that will be really interesting to see, well, what does that do in terms of impacting human behavior? So we talk about the AI being potentially biased, but are we biasing human behavior by putting in a piece of AI? So what does that do? What does that show? And how might that work? And then the jewel in the crown really is the prospective study. So what is happening when we put MIA into a workflow and we actually start seeing how it performs in real time? And ultimately, the aim is to safely deploy MIA into NHS breast screening. That's where we want to get to at the end of the 3 years. So that's the overview. I think this infographic sort of echoes what Nisha said. This is slightly out of date now. Royal College of Radiologists haven't published a newer one, so this is the latest one I could find. But in terms of the workforce crisis and about how we address that within breast screening, you can see some of the stats on there. I think the big one at the bottom there is about 38% of breast radiologists expected to retire by 2025. So we know that this is coming up. We know we are going to face those issues even more so than we have now. So it's really interesting to get a feel for the time and the perceptions that people have for how quickly they think we can safely deploy this and what that may mean. So that's us in an overview. That's what we're doing. We are working with our first few NHS partner sites, as shown in the map that Dan put on his presentation. We're very keen to work with other NHS sites. On one of the offers tabs, you can see our website, so you can go and click on there and find out more about us and how to contact us. That would be fantastic, and we'd be delighted to hear from you. So that ends the presentation session. I'm keen to get another quick poll in before I go to questions. We've got a few minutes left. So Rob, if you could launch the next poll. This is really picking up on the bits that that Nisha mentioned in hers, in terms of the areas Nisha and Ellie mentioned about where the areas of AI can make the most impact. So the areas where I feel AI will make the most impact are diagnostics, operational workflows, automation of repetitive and manual tasks, all of the above, or none of the above. So I will give people 30 seconds to record their opinions, and then we'll go through those, and then we'll go into questions. Can see that coming in now. There's a clear leader here. Give it a few more seconds. Okay, 10 more seconds for those of you still to vote. Great. Okay, I'm going to end the poll now. So responses are in. The areas where I feel AI will make the most impact. So diagnostics was 0%. Operational workflows was 3%. Automation of repetitive and manual tasks was 13%. All of the above was 83%. So the vast majority of you think actually AI can impact diagnostics, operational workflows, and automation of repetitive and manual tasks, which is fabulous. And none of the above received 0%. So there is hope there that actually there's a feeling it could be used as great. So we are not barking up the wrong tree here. That's fantastic to see. Thank you very much. We've had a couple of questions submitted in advance, so I'll take others that get put on the chat as well. But I'm going to hand over the first question to Dan, and then I'll go around to others that come through. So Dan, you gave us a bit of an overview in your session. What are your longer term ambitions for the AI Award?
So, I mean, Ellie talked about how ultimately what we're trying to achieve through the work of the AI Lab at HSX is the safe and ethical adoption of AI technologies, and that's really the sort of legacy that I want the award to contribute to. I think to get there are kind of 3 broad areas where we have to solve kind of known problems in the innovation space. The sort of first is around defining the evidence standards and the route to demonstrating that you meet the relevant evidence bars, and making sure that that's sensitive to the risks that we know and understand around AI technologies, and proving that those have been sufficiently mitigated, and that actually we sort of harness the power of AI to improve things like health inequalities rather than potentially perpetuate them. I think the second area is having a really clear reimbursement and commissioning strategy for AI technologies, and that's that's a kind of challenge across other classes of innovation. And there's some really interesting work to think about how are digital technologies, including AI, different, and how should they be remunerated, and what should the commissioning routes be, especially as we move to a world of integrated care systems and we see some structural changes in the NHS that will affect commissioning. And then lastly, I think there's still sort of work to be done around how the NHS uses data and how we interface with innovators around the use of that data, and making sure that we optimize this and sort of protect NHS value, but also help unlock value for patients. And the data strategy that's recently published sort of talks to some of the things we're doing in that area. So I think sort of definitely it's about the safe and ethical adoption at scale of these technologies, but we've got some way to go to making sure that we create all the conditions for that to happen.
Thank you, Dan. Ellie, one for you. You spoke about the AI Lab's wider programs. What do you see as the greatest challenges to getting these delivered?
So I don't see any challenges. No, just joking. My colleagues are so great that everything's going to get delivered absolutely perfectly. No, but being serious, I think actually one of the greatest challenges is ultimately the context in which we operate, because obviously there are varying degrees of digital maturity, varying degrees of data quality within the NHS, and obviously those are huge prerequisites for the kind of whole scale application of artificial intelligence. And so, this is not me copping out and saying, oh, it's other teams' problems, because it definitely isn't. But I do think that context makes it challenging for the AI Lab to really be able to, kind of ultimately achieve its goal. So hopefully one of the things that we're hoping to affect also through demonstrating the potential of these technologies is also galvanize the effort on sorting out those basics. Because, without that, the whole scale application is going to be quite difficult.
Thank you, Ellie. That's really good to understand and see that those challenges can be addressed. Nisha, one's coming for you. You talked about what success might look like in terms of AI being used. What do you see as the greatest clinical barriers to adoption, and how do you think we might overcome these?
I think the one of the biggest barriers at the moment is the headspace, because clinicians are tired. We're sort of, at the moment, I think we're sort of holding ourselves together, but we're exhausted. And so the mental headspace isn't there at the moment. We're being hammered because of targets, service delivery. And so then asking everyone else to then think about other things, it just becomes a step too far currently. And if we weren't dealing with the pandemic, I think it would have been different. So we do need clinician engagement, but what we need to be is efficient in the way that we engage with them. We need to be clear of what the ask is, what we want them to do, and how can we deliver. And I think one of the challenges we've got as clinicians, depending on what organisation you are, your IT infrastructure is not necessarily as robust as it needs to be to support AI. Some of us are still using computers that take 20 minutes to wake up in the morning before we can work. And so then you tell them we're going to use AI, and people become a bit despondent because they're like, well, we don't have the infrastructure in place. So I think that's one of the barriers. But I think as clinicians, we're responsible. We cannot. The way we're working at the moment is not sustainable, and therefore we have to embrace change and innovation to make the environment more sustainable and workable for us going forward. And that is where I think artificial intelligence will play an important role, because it will help with the health and well-being of the individual clinicians that are delivering the healthcare system. And that's really, really important. So we need to engage with the clinicians. We need to make sure it's focused, and we need to make sure that we can act upon that engagement. So I would say that when you go to the trusts, you need to check that the trusts are invested in wanting to work with AI. They're willing to invest and do what they need to build the infrastructure, and then you get the clinicians involved. And when the clinicians see that there's buy-in from their organisations and investment, then they will engage in the process. So I think that's really, really important. A lot of clinicians are driven and they're trying to embed AI. But again, the challenge that you have is Is it low risk? Is it high risk? What does that mean for the service? What does it mean for the patients? Who's accountable? You know, so there are a lot of barriers that the clinicians will put forward, which we need to give them confidence and assurance that we can deal with those. So there is a lot of work that needs to be done in this area, I'm afraid.
Yeah. Thank you, Nisha. And your answer has actually picked up the question that was discussed in the chat as well. So thank you very much for picking up that one. I'm aware we're drawing to a close now. I want to make sure we finish within the hour. We have had some other comments through. So the key question is, will this be available after the event? Yes, this event is being recorded and it's going to be shared as well. We've had a few other specific questions about some processes, so I'll pick those up afterwards. But thank you so much to all of our panel. And thank you to you for joining us today. We hope it's been informative, interesting, and hopeful in terms of where AI can go. And thank you so much for your time. Thank you for joining us.
Thank you.